So, welcome to this next session on the journey to net zero healthcare, tackling Scope 3 emissions for people and the planet. I'm joined by Simon Monk, Health and Climate Leader for UCL Partners, Andrew New, Chief Executive of the NHS Supply Chain, Paula Franklin, Chief Medical Officer at Bupa, and Fiona Adshead, Chair of the Sustainable Healthcare Coalition. So Paul Pullman said earlier this morning that companies should do less harm and do more good. And I feel that this is really fitting for the healthcare sector, which has lagged behind other sectors in reducing emissions. And today we want to talk about Scope 3 emissions, how healthcare systems are collaborating, how do healthcare providers work together, and where does the patient come into all of this? Because at the end of the day, you have a patient that either gets better or doesn't. And if healthcare was a country, it would be the 5th largest country in the world. So that's seeing the environmental impact of the healthcare sector. I think before we get started, it'd be quite interesting to know how many people are in the healthcare sector. If you could just raise up your hands. Okay, and how many of you have been in a hospital maybe when you were born? Everyone, hopefully. Great. So there is some context to be made. When we're talking about Scope 3 emissions, I think I'd quite like to put it into context. If we start at where the low-hanging fruit are in terms of Scope 3 emissions and we work up to the top. But what are you looking at? So what are the biggest areas of emissions in the supply chain? Andrew, you've done a lot of work with the NHS to look at levers, abatement levers. Where are the biggest building blocks or the biggest chunks of emissions in Scope 3?
The Scope 3 emissions vary massively by care setting, and this is really important because it's not going to be a one-size-fits-all solution. If you take a typical acute setting in a hospital, you may have 20% of emissions based on the built infrastructure and operating the hospital. You may have 10% based on people's travel to and from the hospital. And then the vast majority of the remainder is made up on the supply chain, on the products that are bought, consumed, used throughout their life cycle. And of that, 40% of that remaining two-thirds is on medicines, and the rest is on really product that is bought into and used within a care setting. So the answers to each one of those have to be different, because for us to attack the whole, we're going to have to attack each different element with different levers, and that needs different skills, different focuses, different capabilities. And your low-hanging fruit sits differently across all of them. Whether it's modernising electrical circuitry, whether it's changing heating systems in the physical infrastructure, whether it's considering the number of trips people need to take to go into a care setting to reduce the footfall, whether it's around packaging or the distance a product has to travel before it's consumed, whether it's about storage and physical infrastructure in the supply chain. All of them have different actions to be taken to achieve a net zero care package as a whole. And it's really important that we do attack each one of them, because actually the population health benefit of us having a lower carbon health system means that actually there'll be less disease in the population. And that in its own right is beneficial because it reduces the demand on the care system, which means we consume less. And again, it's that virtuous circle that we're looking for.
And what approach has Bupa taken? NHS has broken quite a lot of ground with its net zero approach globally, and how's Bupa approaching its net zero target?
So Bupa is an international company, so we have businesses and work and insurance and provision in many countries. And we are also a funder and a provider of care. So it gives us the opportunity to look at this problem from many different perspectives. I think that when we think about our Scope 3, 98% of our emissions fall under the umbrella of Scope 3. So it's a really big and important thing for us because we fund so much care. And these are health events that we pay for that happen elsewhere. So the approach that we've taken really is to work with partners and providers who provide the care that we fund and look at a series of we've started with 6 things that we think are maybe a good place to start. Probably quite obvious, maybe some of them relatively small, but none of them easy. This is not an easy area. So certainly anaesthetic gases that we can look at in our hospitals and also partner hospitals. Medicines, we already heard about medicines, a lot of wastage in medicines and appropriate prescribing and meds management. Food, sustainability of food. We have care homes in many countries, and we also have facilities like hospitals where people eat. And so really looking at how sustainable it is, the food that we purchase and provide for people that are staying with us. Looking at care pathways, efficiency of care provision, that's can have quite a significant impact, and digital health, of course, which is also important. So yeah, I think the final thing is, so it's a bit of a hangover, I think, from COVID. You know, we were all so focused on PPE, and quite rightly so, and protecting patients and protecting our staff. And I think what we're finding as we're moving into a less intense COVID world, that actually there's a lot of unnecessary PPE being used. And so reducing the quantity of PPE and making it more sustainable.
Yeah. So waste is one aspect of that. Actually, as an anecdote, my mum was a theatre sister and a ward sister, and now she comments on the amount of waste, and they used to use the same sets, and they would be reused, and nurses were not allowed to waste anything in the 70s. I mean, Simon, what's your view on that? Is that something that's taken from, is that a view of an older person? Is it true, or where are you seeing the biggest issues?
I'm seeing from our experience, we work with hospitals across London and the southeast of the UK. And when you talk to clinicians and staff in those hospitals about their climate agenda, what they come back to you with is a waste agenda. It's that waste piece which really resonates with people. And I saw that personally as a clinician working in that space as well. I think attacking the waste agenda, really, I think the low-hanging fruit there is to start by focusing on what activity you don't need to be doing. And the reason I say that is that brings those co-benefits. If we can show CFOs of hospitals that doing less activity, whether it's through prevention or shorter length of stay in hospitals, saves money and reduces waste, and also, by the way, improves clinical outcomes, which we know a lot of the evidence, being in a hospital is not good for your health, then we have a win-win-win situation there. And I think that's, for me, that's, from my experience, that's been that low-hanging fruit, or that's the easy way to engage with people in this space. I think you then have to start thinking about some of those harder pieces in the waste agenda about how do we go back to your mum's experience of where we haven't always had use of single-use plastics to everything. We've had that since CJD and things. There's been significant changes there. But in order to shift providers, whether it's in wound care, whether it's in surgical devices, whether it's, from my own experience, in anaesthetic equipment, away from single-use means developing new business models with the pharmaceutical and other industries. And it really requires that collaboration to develop those models of care. And I have no doubt from my experience working with those suppliers that there are financially viable business models in that space, but it takes collaboration.
I'm interested in one of the points that Paula was making about the care pathways, and I know you've been doing a lot of work on clinical pathways. I mean, where are the biggest, when you're looking at it, how much impact can clinical pathways having on reducing Scope 3 emissions?
Well, they're huge. Because that's how care gets delivered. Because I think, we tend to think of health services in terms of, hospitals and clinics, but actually healthcare happens in the conversation that I as a patient have with the clinician who's looking after me. That's where the resource choice gets made often, and that's really where we need to start thinking about how we drive change. And as a coalition, we were formed by colleagues in the NHS to work with industry to really get to the heart of how can you measure where that activity happens, and how can you standardise that in a way so that you can begin to analyse it. So, for example, we've done some work with renal colleagues up in Newcastle, where we've really analysed how a patient would go through a very intensive care pathway, like having hemodialysis for kidney disease, and that basically means that you've got very advanced kidney disease, and it's about 3% of the NHS's budget. And what they found, for example, is there are huge opportunities to change some of how they deliver care. For example, people don't necessarily need to travel to hospital to have their hemodialysis. They can have it at home. But they've also, very interestingly, I think, linking into Andrew's world, the clinicians then begin to ask questions about, well, the fluids that my toxins in my blood get changed with, do they really need to come in such small bags because we're wasting all this plastic? So going back to your mum's dilemma, actually, clinicians of many ages are asking the same question about, how do we reduce waste? And then they want to work with people like Andrew and colleagues because they're not procurers. Many of us trained as doctors, we're not procurement experts. But how can we put this into a framework? So a lot of our work is actually working with industry to kind of really thinking about the opportunities for innovation, because it's not all bad news, it's actually good news. It gives us the opportunity to drive change, to look for innovative products, but also co-create them so that you really have the insights of customers. So as you can tell, I'm very enthusiastic about care pathways because it's basically how you get close to the customer, how you measure impact, but also how you can co-create change.
So we've talked about a couple of low-hanging food. You mentioned food facility. Well, I don't know how low-hanging that actually is, but facilities, I guess logistics as well. But what I'm hearing is that the clinical pathways, you're looking at the care pathway from beginning to end, you need to break that out to be able to identify reductions in Scope 3 emissions. Is that okay? And Andrew, when you then look at the suppliers within that pathway, how do you work together with them? Do you say, okay, these are the NHS net zero goals, you need to keep to them, or how much leverage do you actually have in your choice of supplier? I'm interested in hearing how you then go and deal with the suppliers when you're looking at that pathway.
Yeah, so the topic as a whole is quite a complicated one. Our relationship with suppliers are pretty complicated ones in the first place. I think the NHS in England has been really clear as to the expectations of suppliers by year over the next 10 years as they develop their understanding of their emissions, their plans for reductions, their consideration about the manufacturing footprint, and all the other things they need to do to form a successful low-carbon supply chain as a whole, which is really positive. The negative that comes with that is that a number of our suppliers are major multinational suppliers who are also in other countries and other systems don't have the same requirements that we do. And sometimes you do have that conflict where you're saying, okay, I understand that might only be 2% of your revenue, but to trade in England, this is the requirement that you will have to comply with. And you can see them saying, that's fantastic, but 70% of my trade is in North America, and actually the standards are different. And therefore, how do I try and align the two things? And building that broader commonality of expectation and practice as we move through the next few years is going to be really important to really drive the performance. That said, I've not met one supplier who said to me, yet, I just don't care, or I'm just not interested, or I'm not going to try.
So out of the goodness of their heart, they're saying they're going to go along with it, or do you have some sort of incentives? And
I think that there's always the incentive that the healthcare system in England is a significant one, and it's one that a lot of people want to trade with. It's got a really strong brand. It helps their marketing internationally. But we can see that it's something that really benefits them commercially. And therefore, we do have leverage in that conversation. But it's more people understand as individuals. You meet chief executives of these companies and say, in our world, this is going to be really important. They say, it is for mine too. Let me go and show you what we've done. We've done it because it's the right thing to do. We have shareholders, and shareholders have expectations around how we invest their money. And actually, more globally, this isn't profit over the planet. This is a mixture of how do we achieve both. And we need to work collectively to ride that wave to design a supply chain that's capable of being really low emissions. At the other end, and food's a fantastic example, we could have a supply chain for the NHS in England in the provision of food, which comes mainly internationally, and travels a long way, and food miles are a really negative thing when it comes to the environment. We have a dynamic purchasing system based on regional need, where regional suppliers have the ability to supply into their local care settings. So we've designed a supply chain that fundamentally has a lesser inherent carbon and planetary impact, so a very positive one. But there are choices around how you design supply chains, and that's a professional capability we have, and it's one we have to deploy. But it's one that's shared not just in healthcare, but also in global manufacturing, in FMCG, in retail. We're all asking and challenging with the same questions and learning from each other as to the right way of getting the outcomes we want.
I'd just like to ask Paula a question, though, because you talked about, NHS operates, in this case in England. You are buying from international suppliers, but you have hospitals all over the world.
Yeah, we do.
And how does your experience compare with Andrew? in terms of relationships with suppliers and how much leverage you have and encouraging them to do the right thing out of the goodness of their heart?
Yeah, I don't think they do anything out of the goodness of their heart. I think it's variable. It's quite regional. It's still quite local. I think the ability to extract value internationally in those supply chains is harder in the areas in which we want to focus. And so it's very much about local relationships and local agreements still.
Right.
Yeah.
Mm. And from your experience, Simon, because you then also deal with the individual hospitals that are operating, Andrew's looking at the overall view and you're working with the hospitals. How does that contrast?
I'd say that they're at an early stage, in thinking about their Scope 3 emissions, have been very focused to date on what do they do around their Scope 1 and 2 emissions, and recognising that they, 65-70% of their emissions are Scope 3 emissions, as Andrew's described. And they want to focus in that area, but have a number of challenges. And, what we hear from is, I think, firstly, their local procurement teams lack that expertise for both knowing where to start their focus and B, for really understanding what's greenwashing, what's real in some of those carbon reduction plans they start to see. I think the second piece we really hear from them is a concern that if they push their suppliers too hard, let's say when they're purchasing wound management or pharmaceuticals or whatever, that where there's a limited number of options, that either the cost goes up, or they lose clinical quality. And so they can't sacrifice any of those at the cost of carbon. And I think the third piece which we hear is they struggle with the data in terms of that lack of data, whether it's at supply level or often at a more granular product level, which without that data, they don't know where to focus. And they don't, to Fiona's point, they struggle to understand which of those clinical pathways to focus on, which of those products they need to remove and which are just actually not worth taking a focus on.
Slightly different topic, clinical trials. Fiona.
So we're working on actually looking at clinical trials, and why am I doing that? Not because actually I'm particularly interested in clinical trials personally, but because when you look at pharma companies' Scope 3, like everybody else's, the majority of it is in the supply chain. And actually, when you look at clinical trials and you think about how pharma operates, a third of it is manufacturing drugs, a third of it is distributing them, and then a third of it is developing them. And so we know that it's a big area. We know that actually, when we've looked at all the data on clinical trials, that globally, it's the same impact as Belgium as a country. Belgium as a country. That's big. So I'm interested. And innovation is really important because it's the lifeblood of the industry. So we brought together a coalition of academics who've also been interested in this, industry, to look at how can we come up with an eco-design approach where we're looking at sustainability of design, we're assessing existing trials, but we're particularly looking at where is the impact. So just like care pathways, there's nothing new. We're breaking it down into the activities, the patient's journey through there, and then we're trying to look at where the opportunities are. But I guess a few things that reflect a little bit on the industry, as we'll have heard throughout the last few days, they are subject to the same capital market rules as everybody else. Mm-hmm. Capital investment is now expecting healthcare industry to be sustainable. That's equal to other sectors. I think increasingly the public will expect that. But actually, when you look at one of the reasons why people are really interested in clinical trials is because there are huge cost savings to be made. And so there's been a big boom since the pandemic in trials which are basically delivered digitally, so-called decentralized clinical trials, which basically means patients can stay at home and have research done on them. And there's a big opportunity, as Paula was saying, about using digital.
So the trials are not just about the medicine that's going to be used, it's actually about the way that it's...
Yeah, and also, finally, Andrew and his colleagues have kind of told the industry that they're going to have to report on Scope 3. All providers of the NHS over a particular contract size, I think it's 5 million, will need to do this. So that's most people. And they know that because they're now going to be asked the questions around how can you carbon footprint your product or device, that the same is going to happen for clinical trials. People are going to start to. And also they want to know it themselves, because the companies that are really advanced on this are already talking about how that they're saving a lot of money, because a lot of Scope 3 is done on your financial spend. But once you start to analyse where the cost for the environment, but also your financial cost really goes, then you can challenge yourself using, do we need all this travel? Do we need to be shipping samples to centralised labs? But what it does mean is it brings us back really to collaboration, because we then need to work with colleagues in the NHS and in regulators to say, well, you require us to do this, to ship all our samples to this lab wherever, individually. Why? And
is that the case, Andrew? Would
why?
you agree with that?
I think this will only be achieved collectively.
Exactly.
And I think there are challenges to each other and challenges to and from suppliers and to care professionals and to clinicians and medics, to everyone else, to say, actually, we need to all change our behaviours and our approaches and what our expectations are to successfully deliver the patient outcomes we're looking for.
But are you challenging your suppliers to do that? Are you going and saying, this is not being done in the most efficient way, we would like to see new technology, we'd like to see a new approach?
Yes. I think I think we're still in the stage of this where by collaborating with suppliers, identifying areas where different suppliers are achieving better outcomes and sharing that information, they're gaining the efficiency benefit and removing the waste from their organisations, which has got a financial benefit to all of us. So I think we're still on the path towards this being a way of making the healthcare system more efficient and more productive, and I think that's very positive. At some point in the future, we know we will receive challenges in that traditional space. Essentially, you can't get to the point where you're changing a hip to have no raw materials in it. We'll always have raw materials in there. One of the challenges around care design and pathway design is how do we redesign care at the holistic level to eliminate some of those highly intensive items, but still deliver a better patient outcome at the other end. Yep. And that's that longer term thinking. So at the moment, we're focused on the next 4 to 5 years of minimising the environmental impact of what we're doing now, working with suppliers and their innovation pipelines to the future, and understanding different routes to treat illness, but also to prevent illness or to monitor conditions, knowing that in the future, hopefully, a lot of the intensive things we currently buy today, we won't need at all in the future. So we're going through waves of change that we have to deliver to minimise impacts and to design what the future of care needs to look like to have that net zero healthcare system that we're moving towards.
And are you pushing this sort of innovation and as well?
Yeah, I think as you can hear from the conversations, this is complex.
Yeah, it's very complex.
And there are several fronts that you have to push on. I suppose the thing that's front of mind for me is that the core of this is a patient. Yeah. And the patient wants care. Mm-hmm. And the patient doesn't want their care to be compromised by a sustainability activity or goal. And so I think the responsibility is on us to ensure that we can demonstrate that the quality of care is at least as good, if not better, while at the same time that it's a lower environmental impact. I think that's at the core of it. And so engaging not just patients in this process, but also clinicians in the process, because it's the clinicians that the patients trust. Yep. And so we have to have them involved in the process. As Fiona said, the decisions that they make, the choices that they make. Completely agree about the long-term issues and opportunities. There's quite a few short-term ones. There's a lot of waste in healthcare. There's a lot of unnecessary treatments are done, tests are repeated, interventions are performed. So there's quite a lot to go at, all of it quite difficult, and all of it requiring a collaborative approach. Yeah,
that's a really good point about the benefits of taking this approach. And we come back to the point at the beginning. At the end of the day, there's the patient that either recovers or doesn't. And what are the benefits of taking a net zero approach? Does it end up cutting costs? Is there a trade-off? I mean, Simon, what are your thoughts on that?
I'd say I don't see it as a trade-off, and I think our hospitals don't see it as a trade-off. I think where you can deliver those quick wins, as Paul is describing, is where you either show a cost or a clinical co-benefit. And I think 2 examples I've seen come to mind. One is around if you, like all sorts of approaches, if you particularly ask clinicians on the front line, what ideas they have. You find ways to reduce the length of time which patients need to spend in hospital, which improves their experience. They often don't want to be in hospital. Usually improves their clinical outcomes. You often get, for example, better outcomes post-surgically if there's less time in hospital. And if you ask for frontline staff, have all sorts of ways for how you can do that, and including doing less tests, which then means you need less resource and all sorts, and some financial savings from that. The other example which comes to mind is a focus on energy. We've seen, of course, with the cost of living crisis, some of our hospital trusts, their energy bills have gone up 3-4-fold. They're spending sort of £25 million per annum on their energy bills, which they simply can't afford to do. And we're able to show them that if they bring in renewable energy through power purchase agreements, that they get more secure, cheaper energy. And of course, they're signalling to the market as a large public sector purchaser that there's a need for renewable energy. So again, you have that win-win, which you can do quickly. And I think the piece for me is what you're looking here is short-term co-benefits, clinical and cost benefits, and knowing that longer-term you're reducing that impact on the climate, which has also those health benefits.
Yeah. There's a couple of interesting questions here about patients, the link between health and the health of the planet. And actually, there's a point that you just made, Paula, about waste, less treatments, less tests. There's also the point about prevention at the end of the day, that people are not actually going for treatment in the first place. I mean, Fiona, what are your views on that? At the very beginning of the care pathway, is the care not needing to happen?
Well, I mean, I think we've known for decades that prevention is better than cure, because who of us wants to go into a hospital and have treatment? I'm certainly not volunteering, and I don't think, we've already heard that they're dangerous places. So that's absolutely true. I think, but what we find from the case studies we've done, where we look, for example, at the impact of influenza vaccines, that our annual program, or by being able to test women when they're early on in pregnancy to identify who is at risk of complications of pregnancy so that they don't have to wait around in hospital so that people can monitor them. We know that that has a huge impact both for people's health but also for the planet in terms of resource reduction. So it absolutely works. I think what we need to be mindful of, though, is that prevention's not the answer to reducing healthcare costs totally, because what tends to happen is that you prevent some things and then that frees up the opportunity to provide the right care at the right time for the people who most need it. So it's kind of in economic terms an opportunity cost equation. I think, though, the more we understand about sustainability and the more we design it into the system, the more we can make sure that people do get that right care at the right time. So prevention, I think, is critical. And I think we need to keep going at that continuous improvement cycle for all other areas of care, because low-hanging fruit work at the beginning, but as we get more mature in our journey, we need to then get the tougher to challenge things, which is why we need systemic change. And that's why I think people have picked up, does regulation help or hinder? Well, the problem is that regulation is essentially a set of system rules that is designed to get us a system that we thought we wanted yesterday. The problem is, as we move towards a sustainable healthcare system, we need to redesign regulation to produce the care and the operations that we need today and tomorrow. And, for clinical trials, when people were doing regulations, nobody designed all that stuff about samples going centrally. They thought they needed to do that because it got standardized care. Now we know that it has other consequences. So it's the law of unintended consequences.
Yeah. And so, Paula, there was the point on patients asking for sustainable care. Are you actually seeing that? Are they aware of when they're coming for help? Are they just thinking, I'm not well, there's something wrong, I need to sort this?
I think overwhelmingly people feel that they're not well and they want the care that they need pretty much almost at any cost. I think when we're all seriously ill, that's what we want, and that equation doesn't enter their heads. Having said that, I think that when people are not in that acute phase, particularly if they're in an inpatient setting, so in a hospital, sometimes even in a care home, what they and or their relatives may be noticing is waste. And so becoming aware of that. So it's not that they're asking for sustainable care, but I think there's an increasing awareness of unsustainable activity.
Yeah.
I think we've also got to remember that the patients are the people and the people are the population. Before you need to become a patient, you're just a member of society more broadly. And I think at the societal norm, our expectation is that we're reducing the impact on the planet, we are eliminating waste, we are not using single-use plastics, we're doing all the right things. Absolutely right. At the point of acute care, I mean, it's a fix me please, I'm in pain. However, there is that broader expectation that we do see and feel as we talk to people to say, but you are making progress to reduce the emissions caused by care, because healthcare is a significant part of the economy, a significant part of the waste in the economy, it's a significant impact on the planet, therefore you are doing the right things, aren't you? So patient, yes, but population, absolutely yes. There's an expectation now.
So we talked a bit about the patient. I'm interested in leadership and the workforce in the front line, in the hospitals, and how they embrace the challenge. Do they embrace it? I mean, the NHS particularly is facing huge amounts of challenges at the moment on, people out on strike. There's the cost of living crisis. Do they care? How do you get this across the line internally? I mean, Andrew.
Yeah, so mine's quite a simple one. We don't provide enough insight yet to allow people to make great decisions. And this is something that sits with us, actually. It's something we need to do. Where there are two products that do broadly the same thing and we present them as options to clinicians to make a choice, we present them on the basis of their clinical outcome, broadly similar, on their cost. But no one talks yet about what the impact is on the planet. No one says, has this supplier got a cost reduction target? So we're broadening the set of information that we use to make great decisions, not just centrally to set strategies for the future and inform care pathways, but also locally at that point of use. So part of our improvement and modernisation of our organisation is to present a broader range of decision-making factors. Because if you present smart people with a choice, they can make one. And we employ a whole host of smart people. We just don't provide them with all the information to make the choice. So for me to get 1.3 million people to make great decisions, I've got to present them with great data for them to make decisions on, not just assume that the 3 or 4 people who knew in an office somewhere are always going to make the right choice. And that's about integrating the system together and using the groundswell of desire there is to get the right outcomes.
Yeah.
And I think I'd add that, to your point, Andrew, that the healthcare system is full of people who, people of the world. And these are people who at home are used to taking sustainable actions, whether it's recycling or thinking about where their energy comes from. When they come into work, they want to do the same. And they often feel disempowered, from my experience, from being able to do the same. And it's finding those opportunities, whether it's to recycle at work, whether it's to think about how do they reduce waste across their clinical pathway which they're working in. And I think the leadership opportunity here in healthcare is to be able to empower those individuals on the front line, to give them space to take their ideas forward and to be able to prioritise those things which are actually going to make a difference. But I think equally it means thinking at executive level, remembering that those execs are similarly people of the world who frequently have their own children, who are thinking about, the future as well. And there's a real need to move this from solely sitting within sustainability teams within healthcare to seeing that this sits across finance, across procurement, that this is a whole board question here. So I think empowering both frontline and executive is important here.
So they need to be given a choice.
No, just to give some more confidence in that. And it's become part of our decision-making criteria. We need this to become a cultural part of just what we do. And in the purest geek procurement world, with a little bit in my heart that's still there, there is something that's always taught to quality, cost, and time are the fundamentally important things. And when I'm making a decision on the right, that's fantastic. Actually, I also want you to think about labour standards around the world. I want you to think about the environmental impact. I want you to think about whether this is the best way of delivering the solution the NHS needs, not just the product the NHS needs. And they're all training things. They're all investments we need to make in our teams, because it's got to be a culturally embedded part of just what they do every day when they're doing their job. It's a massive leadership challenge, but it's a good one to be involved in.
Great. As we look forward to COP28, there's the Health Day later this year, and I think the UK is leading in reducing emissions and setting net zero targets in healthcare. So if you could, your final comments, or what message would you bring to other healthcare providers, other care providers in other countries? Which collaborative initiatives could you take? Maybe starting with Fiona.
So I think there will be a lot of collaboratives like the Sustainable Markets Initiative talking about what they're doing, what Bupa and other colleagues are doing. I think the key message is that we need to collaborate. None of us have got all the answers. We need to learn together because we've got as much to learn as we have to teach. So I think it's about let's collaborate, let's get it down to the practical problems, and let's just act now and learn through doing.
Paula.
I agree strongly with Fiona. Collaboration is essential. So to be part of that, and we're all learning. But I think that in the business of healthcare, looking after people, we have to look after the planet. It's an equal responsibility. The two can't be separated. And so yeah, find a group and join it and get making change.
I think, for me, if we can see some broad alignment about the challenges we give to the supply base from multiple systems, that's really helpful. The more coordinated approach we take to make it easier for them to fulfill multiple needs at the same time, the faster we'll make progress. So I think there's some leadership we can show in growing that out. But the message is, everything you need to measure it and then do something about it. But don't think you have to measure it to within an inch of its life before you start doing something about it. Yep. We all naturally know where the biggest challenges are, and we can start to make progress today. You don't have to wait for a year before you start work.
Simon.
I would say three things. I think, firstly, I'd emphasise what Andrew said, that I think there's a real need here for common standards globally across health systems. We can't be pushing suppliers in this country, for the pharmaceutical industry, for example, saying these are our net zero targets, but they're not so interested because the targets are more lax elsewhere. And so there's a real need for some consolidation there. I think, secondly, really focusing on those co-benefits and showing some of those case studies of how we've shown within the UK that we can produce improved clinical benefits at the same time as carbon benefits, and similarly with energy improving cost benefits at the same time as carbon. Good. And I think showing that's possible. And I think the last thing I'd emphasise is that if you enable your frontline staff, you can create quite quick change in this space.
Mm-hmm. I think this has been a fascinating discussion. So my takeaway is that I can go and tell my mum it's not just her that thinks there's too much waste. But at the end of the day, it's about the patient. Yeah. The patient, obviously, either they recover or they don't, but they also have to think about the environmental consequences, so doing no harm to the people on the planet. I think that was a great point to end on. Thank you very much to the panellists and to the next speaker, Anthony.